You can go ahead.
Okay, good afternoon, everybody, and welcome to this afternoon's gastro echo session. And today we're having Prof. Martin Hale again for a session on pathology. We've had some interesting cases pass through under the microscope in the probably last 2 weeks, really, with some of these patients still being admitted. And yeah, interesting pathology that Prof has to show. Of course, as always, thanks to the Gastro Echo is hosted by the Gastrohepatology Foundation of Sub-Saharan Africa, in conjunction with Project Echo from the University of New Mexico, and a special thanks goes out to them. The chat will be open for questions, so please place your questions in the chat or raise your hand afterwards. And I'm going to hand over to Prof. Martin Hale then to discuss the two cases. I think I'll give a little bit of background on the first case. This is a young 24-year-old female who suddenly became jaundiced. She went to a local hospital where the story gets a little murkier. She unfortunately had a cholecystectomy done without too much further investigations. Her jaundice continued on discharge, and she went back where they found a bile duct injury on the with excluded segment 5 ducts. Um, she was then referred to one of the HPB colleagues here at Donald Gordon for an ERCP, who did her first chest X-ray and found significantly enlarged lymph nodes. When he performed the ERCP, he also did an EUS, and it came back as classic Hodgkin's lymphoma. Her jaundice and LFT derangement persisted, out of keeping with just the segment 5 being excluded. Her PET scan did not show any lymphomatous infiltration of the liver, but we had worsening LFTs. A liver biopsy was performed on the left lobe, so that it was well away from the site of injury, and Prof. Hale has those results. Prof, do you have both biopsies? Because this young lady had a subsequent biopsy after starting chemotherapy. Yeah, over
Hi,
to you
Bilal.
then,
Yes,
Prof.
I've got both biopsies. Yeah,
Yeah.
thanks. Okay, so thanks, Bilal. So this is the first biopsy that was done. Um, I can't remember, Bilal, exactly how soon after her cholecystectomy, what the interval was after the first biopsy. It was about a month, I think.
2 to 3 weeks. The cholecystectomy
Two or
was
3 weeks.
on the 28th of August, and this biopsy was around, I think, the 11th or 12th of September.
Um, yes. In fact, it was the 25th. This biopsy on the 25th of
Ah,
September.
sorry. Okay, so about a
Right.
month.
No, so about a month. And as you said, that her initial presenting complaint was somewhat vague. She did present with vague abdominal pain, and I think was jaundiced at the time. So this is the biopsy, and I'll share the screen. So this is the biopsy that was done about a month after her cholecystectomy. And can you see the screen, Bilal? Um, Bilal, can you see the screen?
Yes, we
Sorry, I was
can.
on mute. Yes, we can.
Yes. Okay. So at first glance, it, excuse me, would appear to be a good biopsy. And certainly there's no shortage of hepatic parenchyma. Unfortunately, though, in some of these instances, the representation of portal tracts in the biopsies can be somewhat limited, and that sadly is the situation in this particular situation. But if we go through this biopsy, and the approach to liver biopsies must always be systematic, and the systematic approach requires that one observes and counts the number of portal tracts, and then, having looked at the number of portal tracts, assesses the architecture that is present in the biopsy. And histopathology is 9 times out of 10 is a low power diagnosis, not a 40 times diagnosis, but a low power diagnosis, sometimes 25 times magnification, 40 times, and so on. So in this particular instance, this is 100 times magnification. And I'm doing that at this particular level because of the pathology that we're seeing or not seeing. So here we've got a portal tract, and if we look at the portal tract, one needs to look for all the structures in that triad, namely the hepatic arteriole, the bile duct, and the portal vein. So these are the hepatic arterioles. I'll go on to high triad, 40 times magnification, or 400, I should say. And here you can see the hepatic arteriole there, and that there is the portal vein. Now, going back under lower magnification, the next thing to look for is the bile duct. And in this particular situation, there is no bile duct. And bearing in mind that every hepatic arteriole should be accompanied by a interlobular bile duct. And in this situation, that bile duct is not there. And that provides an important reference point in order to assess the number of bile ducts and whether there is bile duct porosity or not. So there is a portal tract without a bile duct. And as we go through this biopsy, we come across, I think that's a central vein there, and we get to another triad here, and we've got exactly the same situation. I'll go under low power examination. You can see that we've got the portal vein. These are the hepatic arterioles, and this is another hepatic arteriole there. Now, as soon as one sees 2 consecutive bile ducts, these portal tracts, in sequence without bile ducts, one has to be alerted to the fact that this is looking very much like a vanishing bile duct syndrome, or certainly that there is some degree of bile duct pathology, because to see 2 consecutive portal tracts without bile ducts is most unusual. As we go through, there's another portal tract, at least another central vein there, and central veins there. There is a portal tract, and in this particular instance, we've got the hepatic arteriole there, we've got the bile duct, at least we've got the portal vein here, and I think we have another hepatic arteriole there. Now, this is often a problem that we are faced when assessing these biopsies, because sometimes the portal tracts are at the edge of the biopsy, as is this one. So that makes interpretation a little bit difficult and a little bit limited, and one has to take a sort of an educated guess, if you like, as to the presence or absence of a bile duct. But certainly, I think when you've got a hepatic arteriole there and another arteriole there, one would like to see a bile duct in their vicinity, and we're not seeing that. So this now is the third portal tract without a bile duct. So clearly, this is now becoming quite a serious situation. And we get to the other end of the core, and then no further portal tracts of any significance. So it looks as though we've got a bile duct, at least a vanishing bile duct syndrome. And in fact, there is another portal tract there. And in this particular instance, you can see there's the vein. Can't see the arteriole in this particular instance, but I think that this here is the bile duct. So it looks as though we've got 4 portal tracts, and there is only one of them that has a native bile duct. So straight away, this puts this into the spectrum of a vanishing bile duct syndrome. I think the other important point to make is that there's no associated inflammatory injury and periductal inflammation. There's no evidence of PSC or PBC or anything like that. The portal tracts themselves are devoid of any inflammatory infiltration. So that's the H&E appearance. So now I'm going to go and have a quick look and show you the retic stain, because we're going to look at the architecture. And I think I mentioned to you that that's the next most important thing to do. And when one looks at the architecture, you can see that we've got what I call a normal trabecular reticular framework. And there is a portal tract there. You've got the bile duct there, and you've got a central vein situated here. And you can see that the trabeculae of the liver cell plates are present. There is no evidence of duplication of the liver cells in those liver cell plates. So that's a normal trabecular architecture. So there's no cirrhosis, there's no evidence of increased fibrosis. I want to go now to the past diastase stain. The reason I'm going to the past diastase stain is to show something else. And that is we are now going to look at the parenchyma. And there is a portal tract there with the hepatic arteriole. Notice the absence of a corresponding bile duct. And then I'm going to move to this area here. And the reason why I put this area on is because this accentuates the presence of intracellular cholestasis, which we've got in zone 3. So just to refresh your memories, here you've got so right in the bottom left-hand corner, you can see there where the pointer is, that is a portal tract. And up in the top of the field, that's a central vein. So the hepatocytes around the portal tract are zone 1. The hepatocytes around the central vein are zone 3. And the hepatocytes in the middle, as one would expect, are zone 2. So the pathology, when we assess pathology, usually that happens initially in zone 3, because it's the hepatocytes in zone 3 that are the most vulnerable to any pathological changes and pathological insults that take place. And in this particular instance, that's exactly what is happening. And when we look at this region here, we've got PAS positive diastase resistant material. That is probably a combination of bile and also ceroid pigment. And then here we've got some dusky brown, greenish material that is bile, which is present in Kupffer cells and also in hepatocytes. And you can see that better represented. Better represented here. Okay, there's a Kupffer cell, there's a hepatocyte, and in the cytoplasm of this Kupffer cell, you've got abundant PAS-positive diastase-resistant material. Remember that the Kupffer cell is part of the phagocytic, the reticular endothelial or phagocytic system. And then there's also a little bit of intracellular cholestasis as well in the hepatocytes, as you can see here. Okay, so we did a CK7 and a P16 on this particular biopsy, and unfortunately the tissue was rather limited, so the CK7 wasn't of much use. And we do a CK7 to assess the presence of biliary pathology and also the presence of bile ducts, stem cell metaplasia, any evidence basically of biliary epithelium that is positive with the CK7. Okay, so Bilal, do you want to? So we suggested a diagnosis of a vanishing bile duct syndrome. Now, without sort of prolonging the discussion, as you know, there's a whole number of causes of a vanishing bile duct syndrome. And one of the commoner causes would be things like bile duct, drug-induced liver injury is a common cause of vanishing bile duct syndrome. And then, of course, you've got other autoimmune diseases, BBC, PSC, and so on. Okay, Bilal, off you go. You go to the continuation there.
Yeah, so we did her various autoimmune markers looking for sarcoidosis, etc., trying to find anything else that could account for this. Specifically, there was no real drug history preceding this episode. She's a young woman who was otherwise quite healthy, not really taking any herbal medications, no antibiotic exposure or anything like that. And so this was a bit of a surprise. The literature does show that classic Hodgkin's lymphoma, which she has proven on the lymph node biopsy, then is a recognized cause of vanishing bile duct syndrome. And we felt that it was attributed to that and started her on some chemotherapy. Um, Once we started the chemotherapy, obviously, in a retrospective way, we can kind of anticipate the fact that the liver function flared somewhat, but this made everyone quite anxious. And a repeat liver biopsy was then requested to ascertain whether or not there was any further injury, any DILI, and also really to reassure the patient that despite worsening numbers, we are on the right track. And so a repeat liver biopsy was requested about 2 weeks back, after she'd had 2 cycles of chemotherapy and the liver functions had flared.
Right. Thanks, Bilal. So this then is the second biopsy, which was done about a month after the first biopsy, and really to reinforce what Bilal was saying, we were somewhat perplexed by this patient because of the fact that had been a well woman. There was no evidence of any over-the-counter medication, antibiotic therapy, or anything else that could potentially be a cause of this vanishing bile duct syndrome. And in fact, at the time, she was found to have a widened mediastinum, and that's when further investigation of that revealed the presence of Hodgkin's disease. So this now is the repeat biopsy a month later. And here one can see straight away uh, under the low power lens that there's clearly an increase in the degree of cholestasis in zone 3. The architecture is maintained, and as I mentioned earlier on, first thing to look for is the number and to assess the number of portal tracts. And here we've got a portal tract there, and you can see that we've got so I'll keep it on this magnification. And here it shows a good relationship and what one would normally see in the various structures of the portal tract. So there's the hepatic arteriole there. Here we've got another hepatic arteriole, and this structure here is a bile duct. And notice the proximity of the bile duct to the hepatic arteriole. And in fact, we call that, and you've probably seen in the books and the literature, the literature talks about it, or we talk about it, as paired hepatic arterioles. And what we mean is that the hepatic arteriole is paired with an accompanying bile duct. There is the portal vein. So that's the sort of thing that you would expect to see in a normal portal tract. Notice that there's a complete absence of any inflammation, as we saw in the previous biopsy. So there's no evidence of Hodgkin's disease actually in this particular biopsy. Once again, notice that the architecture is maintained. And going to zone 3, so there's a central vein, And these are the hepatocytes in zone 3. And you can see that there is marked intracellular cholestasis and also intracanalicular cholestasis. So these structures here, these are the biliary canaliculi between the hepatocytes. And you can see that some of the hepatocytes for example, here contain intracellular bile. There's also intracellular bile, which has been phagocytosed by the Kupffer cells. So it's profound zone 3 cholestasis. The other thing that we also have, and that seems to be limited to zone 3, but the other thing that we also have are these foci, as you see here. So there's zone 3, and we recognize that because of the zone 3 cholestasis. And here in zone 2, there's this focus of cytoplasmic clearing of the hepatocytes, and you can see that many of these hepatocytes, in fact, contain intracellular bile, and we call this a bile infarct. Okay, so this is an unusual thing and only occurs when there's quite severe cholestasis. And there's several such bile infarcts through the biopsy, as you see there. And then I think that's probably another bile infarct. And again, another bile infarct there. And as you can imagine, it's quite difficult actually sometimes, and we had to sort of look at this very carefully to make sure that some of these structures weren't in fact portal tracts. There, I think, is a portal tract with the hepatic arteriole. Oops. That's the hepatic arteriole there, a little bit distorted with the portal vein, but there's no bile duct. There's another infarct here. And so there's several of these infarcts as we go through the biopsy. And there is a portal tract there with a native duct. And once again, you can see the proximity of the hepatic arteriole there as compared to the location of the bile duct there. See how close they are together. So if you see a bile duct, you usually see a neighboring hepatic arteriole. So the converse then is what one would expect, that if you see a hepatic arteriole, you would expect to see a bile duct in its proximity. And if you don't, then that acts as a red flag. Right, so now, in this particular instance, there was sufficient tissue to demonstrate bile ducts. And what I've done is I've just picked up two, when I find it. So unfortunately, with histopath, you've sometimes got to imagine where things are or anticipate and think in sort of 3 dimensions. But this is a portal tract, and luckily we've got a native duct. And this is a CK7 immunohistochemistry stain, and the CK7 picks up the cytoplasm of biliary epithelium. So that's the native duct there, and this brown stain there represents stem cell metaplasia of hepatocytes, because the hepatocytes are undergoing morphological changes in an attempt to eliminate the excess bile. So that's what a native duct looks like on immunohistochemistry staining. And then if we go up to this end here, this is another portal tract. And here you can see that we've got this staining at the periphery, and that's all stem cell metaplasia. But notice that there is no native duct in that portal tract. The other thing that also happens sometimes is that you get stem cell metaplasia in zone 3, and that's exactly what we're seeing. So this here This corresponds to the foci of intracellular and intercanaliccular cholestasis in zone 3, and that stem cell metaplasia, which is occurring because of the marked cholestasis that is present in this patient. So in summary, then, what we're dealing with is a patient who has vanishing bile duct syndrome, and probably as a consequence of her Hodgkin's disease. And just as a way of a bit of background, the vanishing bile duct syndrome is a well-recognized but rare paraneoplastic syndrome of Hodgkin's disease. And if you look at the literature, in fact, there are only isolated case reports. The prognosis is variable. There have been some patients who have survived and they have recovered liver function, and homeostasis has been recovered within 4 to 6 months. But in other patients, the disease has been progressive and has been fatal. But the literature does report various therapeutic regimes that are liver friendly to the biliary epithelium, and some patients have recovered. Interestingly enough, I suppose also most of the patients have been young. There seems to be a preponderance of women in the case reports that I've seen, one or two males, but the majority seem to have been women, and women in their 20s. But then that's really the age of Hodgkin's disease, as we know. So, yeah, uh, interesting, interesting case. First case of vanishing bile duct that I've seen associated with Hodgkin's. Bilal.
Yeah, it certainly is an interesting case, and we are quite concerned about this
Okay, Bilal.
poor young lady. Hi, Prof. Can you hear me? Hello? Can you hear me?
Yeah, can hear you.
Oh, okay. Sorry. So I was saying that we are concerned about this young lady and her prognosis. At the moment, she's still looks good. Isn't necessarily still has a good ECOG. And I'm hopeful that with continued chemotherapy, we can ride this out and have a good outcome. But it is certainly a concern. I see Prof. Cassinides has his hand raised.
Thanks.
Prof, go ahead.
Yeah, thanks a lot. Can you hear me?
Yeah.
Martin, if you look at all the causes, if you look at vanishing bile duct syndrome, there are a lot of causes and a lot of outcomes. Are there any histopathological features which can aid us in determining what the kind of outcome will be?
So Chris, not that I'm aware of. It would seem that, I think histopathologically, I think it's difficult to predict which ones are going to recover and which ones are not. I think you've got to look at it from a biochemical point of view.
And Bilal, do you have a
It
feel?
certainly is. It certainly
Can you hear
is a
me?
difficult one to make with these patients are often sitting with very high bilirubins and high alkaline phosphatase levels, and then you sometimes get just a sudden turnaround with their numbers suddenly dropping. I'm not aware of any specific um, I'm not aware of anything specific that can predict who has what outcome. I'm not sure if Wendy
And,
or
and
Mark are on the meeting, and maybe they may have some input. I don't see them, but Liz, you're next up in line then.
And no, Les was here.
Oh, is she? I didn't see her. Sorry, apologies, Nelly. Either of you guys want to comment? Good grief, where's Nelly? I still don't see her.
Sorry, sorry, no, she's
Okay. No, doesn't look like it. All right. Okay. So yeah, we just hope for the best for
Bilal,
her.
could I,
Yeah,
yeah,
who's our next
Bilal,
case?
could I ask, is she on
Capacity of
No, I
sucrolic
was just going
acid.
to ask you on the chemotherapy. Uh, yes, and there's a variant of rituximab as well that I can't remember offhand what it was called now, that some of these patients have been on.
Yeah, I'm not sure.
Um,
I know she's on an AVB regime.
yes, yeah, it's apparently liver friendly.
Yeah,
Okay,
yeah.
right.
No,
So next
I didn't think
patient,
it was
Bilal,
the
that
chemotherapy.
I've got, no,
Okay.
no. Uh,
All right.
but bearing
Let's
in
go on
mind,
to
of
our
course,
next
while we're
case.
talking about chemotherapy, sorry, Bilal, but while talking about chemotherapy, bearing in mind that you can get a veno-occlusive disease or sinusoidal obstruction syndrome often in patients with chemotherapy, which this
Yeah,
is not.
especially the platinum-based chemo
Yeah,
therapies.
yeah.
Yeah. Okay,
Okay,
let's move on
next
then.
patient is AV, Mrs. AV, 73-year-old woman.
Yeah. Let me try and find my notes on her quickly. This is a 73-year-old woman that came in with a mixed picture. Um, Let me just pull up. Uh, Apologies, everyone. Let me just get my notes. Ah, dear, Prof, would you mind giving a bit? I think you may have a bit of the background on her. For some reason, I cannot
So,
find my notes.
yes. So she essentially presented, she was, or she is, I should say, she's 73%, was found to have abnormal liver function, and uh,
Ah, yes.
also, also had pruritus and fatigue. And
Yeah,
whenever you tell us that, the first thing I think of, as you guys do, is BBC.
yeah.
So you investigated her, and I don't know if you've got the bloods there.
Uh,
I've got the bloods if you want to read
you've
them
got
to
it.
you.
Okay.
Okay, so she had a total Billy of 30, the conjugated fraction of 12, ALP of 124, a gamma of 81, ALT of 62, and an AST of 96, total protein of 57, and an albumin fraction of 29. Platelets were 107, and she had an INR of 1.2. So that's concerning. She's got a low platelet count and a low albumin, and also slightly elevated INR. Autoimmune showed a positive ANA with a titer of 1 in 80 and a speckled pattern, a high positive Rho 52, a positive AMA M2, and she had immunoglobulins of 16, um, and an IgA of 1.4 and an IgM of 1.7. So I think that, as I recall, when we discussed her pathology, I think the question was, did she have autoimmune hepatitis? But she had a little bit of a mixed clinical picture, and also, of course, that positive AMA M2, which, as we know, is concerning for PBC. I'm not sure whether she had positive GP210 or SP100. I have an idea that those were negative,
Yeah.
um, but I don't recall that at the time. It would have been mentioned if it was positive. So anyway, you did a liver biopsy on her. And in this particular instance, I'm going to show you the retic first. Okay, so there is the reticulin stain. And you can see straight away that we are dealing with a cirrhotic picture. You can see broad bands of fibrous connective tissue here surrounding regenerating hepatocellular nodules. And one can see that there is also a significant degree of trabecular disorganization to the reticulin framework. The biopsy is somewhat fragmented, but one expects that in the cirrhotic background. Here you can see that there's twinning of hepatocyte plates. And the reason why you get the fragmentation of the biopsy, as is demonstrated here, because the fragmentation and the separation of the core happens along the fibrous connective tissue planes. And then if we look at the serous red, you can see broad expanses of collagen separating out these regenerating nodules. The serous red is a wonderful stain for demonstrating collagen. I think it's far better than the mass-on trichrome. The mass-on trichrome is a tricky stain to do with the differentiation, whereas the serous red gives good definition. The other thing about the serous red stain is that under polarized light, you can also determine whether you've got type 1 collagen, which is essentially irreversible type collagen, or type 3 collagen, which is potentially reversible. And that's useful from a prognostic point of view. Okay, so that's the architecture. And then the next trick is to work out the cause of the cirrhosis. Okay, so what we have is, and I often refer to this as the sort of blue biopsy. And the reason I say that is because of the intensity of the cellular infiltrate that is present in the fibrous connective tissue. And you can see that here. And typically that occurs in cases, or commonly occurs in patients who have autoimmune hepatitis. And here you can see that accentuated. You can see this aggregation. These are all aggregates of lymphocytes and plasma cells. We'll go and have a look at that closely just now. So here you've got the aggregation there and there. And then we go and have a look at this. We can see that there is a mixture of cells. Just trying to find. So there's one plasma cell there. I can't see any clustering just yet to demonstrate to you. Okay, let's go across to here. So here we are. Got to look for them sometimes, but here you've got a group of plasma cells there, another one there, another one there. And that is abnormal. You don't really want to see clustering of plasma cells in a liver biopsy. That is highly suspicious for autoimmune hepatitis. And then there's another group of plasma cells here. Once again, there, and there. You can see that plasma cell there with a typical perinuclear half. And then while we're on plasma cells, just to go back to this core here, and just to demonstrate the immunoglobulin, and that cell there, you can see that there, that's a plasma cell, and these are what we call Russell bodies, and these are globules of immunoglobulin that are being produced by that plasma cell. So typical appearance of Russell bodies in a plasma cell that's producing lots and lots of immunoglobulin, noting that her IgG was only 16. I mean, it's at the top end of normal for the lab concerned. There are also a few eosinophils in the biopsy as well. And so I'm going back between various cores because I want to show you different things. They're not always present in the same region. So here we've got interface inflammatory activity, and there's a plasma cell participating in this interface inflammatory activity. And the presence of plasma cells in interface hepatitis is a very good predictor of autoimmune hepatitis. And then the other feature that you also see, but not always, and I personally have a lot of difficulty convincing myself sometimes, and that is the presence of imperipolesis. And that is the phagocytosis of lymphocytes by hepatocytes. And that's one there. And you can see at the bottom of the screen, I'll just move it up a bit. So there you can see a hepatocyte, and there's a lymphocyte. And there is another one across here. And that, again, I think that's a hepatocyte nucleus there, and there's a lymphocyte, and you can see it sitting in a cytoplasmic vacuole. Now, the problem that I find all the time is separating out cells like that from this sort of picture here. And these are lymphocytes that are sitting in the sinusoids. So you've got to be careful that you don't mistakenly call lymphocytes in sinusoids lymphocytic imperipolesis. And there, just by way of another thing, I think that's another plasma cell there, also participating in this interface inflammatory activity. Right, so now we know also from a serological point of view that this patient has got positive AMA and AMAM2. And if we now pay our attention to the bile ducts, we see that there is clearly evidence of bile duct injury. And if we look here at this duct here, one can see that there's significant nuclear anisocytosis, nuclear hyperchromasia, and attenuation of the epithelium. So this is a native duct here. And I think, in fact, this is also part of the duct as well. So you've got angulation, you've got epithelial attenuation, cytoplasmic vacuolation, and that is a very worrying feature for inflammatory mediated injury to the ductular epithelium. And if you just take a picture in your minds of those changes there, you can see that there are similar changes occurring in other ducts. For example, this one here, and I think to a lesser extent, for example, in this one here, and probably that one there. And I thought similar changes again in that duct there, and likewise that duct there. Now, if we look at this particular duct, often epithelioid histiocytes, I think it is in the eye of the beholder sometimes, but I'm not sure, for example, whether this could be a periductal infiltrate of epithelioid histiocytes. One is, in a typical case of PBC, one sees a granulomatous or periductal granulomatous inflammatory infiltrate in the ductal epithelium, but it's around the bile duct. Notice again this one here, the longer one looks at these things, the more changes you see. And you can see here, once again, a native duct. You can see the cytoplasmic vacuolation. And then in this duct here, you can also begin to see lymphocytic inflammatory exocytosis. These are lymphocytes that are migrating into the ductal epithelium. And we discussed at the liver meeting, in fact, I think it was last week, the question of autoimmune cholangitis and the relationship of autoimmune cholangitis in patients who have autoimmune hepatitis. And I think it's Max Sween's book actually says that that term is reserved for patients who have BBC-like changes in the ductal epithelium, but they are seronegative for the markers for PBC. And then last but not least, there's also evidence of spotty inflammation, such as you see here in the parenchyma. So she has got, I think, probably autoimmune PBC overlap, and difficult to really decide which component is dominant. The ductal changes are quite significant. She's got positive serology, I think probably co-dominant. If anything if we were sort of forced to call which one is dominant, then I'd probably say the autoimmune component is dominant at the moment, but that may change. And then moving to the CK7. So this is a CK7, and here you can see these are native ducts, and the native ducts are recognized by their uniform appearance. In cross-section, they're usually round. That's probably a proliferating duct by virtue of its angulation, but this is all stem cell metaplasia and bile ductular proliferation. Now, one of the tricks that we use now is also to look at biliary epithelial cell senescence. And in patients with vanishing bile duct syndrome, PBC, PSC, anything that's causing epithelial injury, the P16 will be positive. And it can be quite scanty and difficult to see. In fact, one first picked this up when we were looking at cases of Alagille syndrome and biliary atresia. And in fact, there are increasing reports now in the literature about the identification of P16 positive biliary epithelium in patients with PBC and PSC. And we've certainly seen a number of cases now over the years that demonstrate that. So this is a native duct here. And from my own point of view, I only consider a positive signal when I see this. So this is the cytoplasmic staining. This is a native duct, and I only consider it positive if you see it in native ductal epithelium. And the reason I say that is because you will also see it in stem cell metaplasia. And whilst I haven't been able to see anything in the literature on this, my own rationale would be that because you've got ductular proliferation, one would expect to see epithelial senescence as well. So the P16, if you like, is a brake on cell division. So what happens if you just think of the cell cycle, you've got the accelerator, and then you've got the brake on cell division. And one of the brakes on cell division is P16. So that's why we use P16 to demonstrate biliary epithelial cell senescence. So I think it's a good example of that. And I think that the fact that we got the biliary epithelial injury is actually supported by the P16 staining. Although, I mean, she does have clinical symptoms of PBC as well. Okay, Bilal, over to you.
Sorry, couldn't find my mouse. Yeah,
Right.
so we've started her on some treatment and sent her on her way. And we wait to see how that treatment
Right.
changes her liver function tests.
Got one more
Uh,
patient we could do quickly.
we've got 5 minutes. I think maybe let's rather open the floor for questions.
Sure.
Seeing as they were similar cases, I'm not sure if we're going to be able to go through do the case
Yeah,
justice in 5 minutes, Prof.
I
So,
agree.
any comments from the floor then? Um, so essentially, these are cases where we're going to need to treat. We've got features of overlap in that we have serological evidence to support both, as well as histological evidence. So we are starting on both immune suppression as well as acidoxycholic acid. She is somewhat older than our normal young autoimmune type patients. But remember, PBC especially has a bimodal age distribution with a second hump with patients in their sixth and seventh decades. Although it's not 100% keeping, it is actually associated that there is this bimodal age distribution. Um,
Well,
Bilal,
Bilal,
perhaps,
can we
perhaps
start?
I could
Go, Martin.
carry on, Chris.
No, no, you
No,
go.
I was going to ask Bilal, perhaps Chris yourself as well, because you had the three of us actually discussed the question of how serious it was, or no, maybe I should rephrase it, that it wasn't that serious to miss a PBC in the initial phases of the disease. Obviously, the autoimmune component, important not to miss it. But PBC was a slow, more slowly evolving disease. Would you like to comment on that between the two of you?
Go, Bilal.
so I think just more the severity and severity of an autoimmune hepatitis that you have a 5 year survival of untreated autoimmune hepatitis mirroring metastatic malignancy with patients that can decompensate quite significantly. I think something that's also just important to emphasize about autoimmune hepatitis is to treat to target. I know I'm borrowing a phrase from the IBD guys, but it's especially underlined for autoimmune hepatitis. If you don't get that IgG into normal territory and those enzymes normalized, you are still progressing towards cirrhosis. You've just delayed the destination as opposed to averting cirrhosis. So, treat to target, untreated autoimmune hepatitis is very bad. I think PBC is less likely to be a fulminant disorder, and so certainly you do have some time, but I think just the phrasing of it I wouldn't want to miss a PBC either because of the significant lifestyle ramifications that it has. These patients really do suffer with pruritus. They suffer with the fatigue, a lot of which is made better, but not necessarily entirely controlled by treating the PBC.
Yeah, thanks. Yeah. I mean, for me, as soon as I see positive AMA, GP210, SP100, my diagnostic parameters are highlighted.
Narrows it down. Certainly does narrow it down.
Yeah.
I still don't see Nelly on.
Starting one,
Uh,
could you make a case for starting one, treat
One at a
one?
time.
Yeah.
Yeah,
I
yeah,
mean,
absolutely.
they might not contribute equally to the clinical abnormality or biochemical abnormality.
So I think that, if you have PBC and you don't have the hard evidence for autoimmune hepatitis, treat the PBC first. Treat the PBC first, see what happens. But where you've got such convincing evidence of an autoimmune hepatitis overlap, I think we're committed to treating both.
Yeah.
Yeah. Liz, you're done with your exams now, so you get to have some input. Are you on? Okay, just join for CPDs. All right. Guys, it is 5:30 exactly. Prof. Hale, thank you so much for once again putting on a pathology masterclass for us. The Remember to put sorry, remembering to thank then the University of New Mexico Echo team as well as Echo India for their efforts in putting all of this together. For putting all of this together. And remember to join us next week for upper endoscopy or upper GI endoscopy session.
Thanks,
Okay.
Martin. Bilal.
Thanks, everyone. Cheers. Bye bye.
Bye.